All right. So almost 70% of the delegates feel that it is throughout the cycle. Very few people are thinking that it is during expiration, and 20% people are thinking it is at the end of inspiration. So with that, let us start the talk. As we all know, atelectasis and low FRC, as Dr. Namit Jarat sir already shown, increases the pulmonary vascular resistance and right ventricular afterload. And this particular study by Tremblay et al., landmark study, kind of showed that atelectasis also promotes inflammation and lung inhomogeneity. This was a classical paper by Mead et al. Published in 1970, which showed that with a transpulmonary pressure of 30 centimeters, at that time it was considered to be a very safe, even now, 30 centimeters of transpulmonary pressure, at the junction of the atelectatic alveoli and the normal alveoli, there is a area where the transpulmonary pressure can go as high as 140 centimeters of water because of stretching. And this is also called as stress raiser. So lung inhomogeneity, the more the patchy areas of atelectasis, the more you will have lung inhomogeneity and more stress raisers. And by recruitment maneuver, what you are trying to do is remove this lung inhomogeneity and reduce the stress raisers. Under the term recruitment, there are two different conditions which has to be fulfilled. First is regaining the aeration in atelectatic units, which we all know, and also regaining in a poorly aerated unit, which may not be atelectatic. Again, you are regaining the aeration in that. And both are at the end of inspiration. This is very important. Although when we are applying a recruitment maneuver, we increase the PEEP, but recruitment is basically at the end of inspiration. There are different methods, as we all know. Sustained inflation, staircase method, prone positioning is also a type of recruitment maneuver. Ventilatory strategies like HFOV and APRV. We are going to have a very good debate post-lunch on APRV and proning. Sustained inflation, we all know, if you connect to a Bain circuit and then with a manometer, keep the pressure up at 30 centimeters of water for 30 seconds or 40 centimeters of water for 40 seconds, or keep the patient on CPAP mode and increase the end expiratory pressure to like 30 for 30 seconds or 40 for 40 seconds. This is basically sustained inflation. While a staircase type of recruitment maneuver is where you start from a PEEP of say 5, go on increasing in the aliquots of 2 centimeters each time, monitor the inspiratory plateau pressure, and maintain constant driving pressure, in this case 15 centimeters of water. And in children, generally we stop at 30 centimeters of water or 30 seconds. In adults, you can go up to 45 seconds, 45 centimeters of water. Once you achieve a recruitment, then you come down, and when you're coming down, again reducing the PEEP in the aliquots of 2, then you monitor the compliance, gas exchange, etc., and titrate the PEEP at the, this is called as a decremental PEEP titration. So you are titrating the PEEP on the descending limb of the PV loop. There are two important terms which have been recently coined by the European Society of Intensive Care Medicine. Prolonged high pressure recruitment maneuver, where you keep the inspiratory pressure above 35 centimeters of water for more than 1 minute. And brief high pressure recruitment maneuver, where you keep the same pressure of 35 or above centimeters of water for less than 1 minute. So with this background, let us go into our discussion today of how to quantify recruitment maneuver, which is quite controversial. Classical methods, CT scan, which is considered as a gold standard, lung ultrasound, which is catching up very rapidly. These are two things which are quantifying, and also looking at the change of the respiratory compliance in response to application of PEEP, which can be by PV loop, stress index, or recruitability index. So coming to CT scan, from 1990s, Dr. Luciani Gattinoni has been studying this, and he divided the lung regions into non-aerated, poorly aerated, normally aerated, and hyperinflated, depending upon the Hounsfield units. But as you can see, it is stopping at 1000 units, and in CT scan, hyperventilation of hyperaeration of above 1500 to 2000 Hounsfield unit is not detected by CT scan. And this method which he described was a single CT scan method. The percentage of recruitable lung was defined as a lung which was atelectatic, totally unaerated at a PEEP of 5, and after increasing the pressures to 45 centimeters of water, whatever aeration happened in that percentage, that is called as a recruitable lung. There is another method where two CT scans are done, one at the lower PEEP, ZEEP or a PEEP of 5, and then with a special software, there is a delineation done manual delineation is done between aerated, poorly aerated and atelectatic lungs, and then a PEEP is applied, and again a manual delineation is done at PEEP, and they are kept side by side and then compared. So as we can imagine, the second method of taking two CT scan and comparing will provide more information than doing only a single CT scan. Lung recruitment by ultrasound, the Dhiren sir has explained so nicely. This particular thing is very rapidly developing. This was a very recent last year's systematic review and meta-analysis of the RCTs, where they compared ultrasound-guided recruitment versus non-ultrasound, and they found that ultrasound-guided recruitment maneuver improves the lung aeration, reduces atelectasis compared to non-ultrasound guided. One more study, which was published in 2018, this was a randomized control trial between lung CT scan and ultrasound at different PEEPs. They showed that lung ultrasound is reliable for assessing global and regional lung aeration, but not PEEP-induced recruitment. So what basically it means, as sir already showed, that if alveoli are totally atelectatic, lung ultrasound is good. It can show how much new areas have developed aeration. But if there is already some aeration and then better aeration is happening, lung ultrasound and CT scan usually don't show much. This was one of the most important study by Borges et al. Published in 2006, where they did a staircase method of recruitment maneuver and then assessed the by CT scan and gas exchange methods. They use this particular index PaO2 plus PCO2 above or equal to 400. So even at 60 centimeters of recruitment, if this was not achieved, it was called as a failed recruitment. After the recruitment, they also did a decremental PEEP titration, and in their study, they found there was a strong inverse relationship between arterial oxygenation and percentage of collapsed lung. That is fine. But more important finding was they found that whatever recruitment you achieve after whatever 40 centimeters or 60 centimeters of water will be maintained only by a good PEEP, which has been titrated by decremental PEEP titration. So this is an important finding. How to understand that? At 0 PEEP, suppose your lung is like this. Normal PEEP titration at the bedside, how we do? We just increase the PEEP by aliquots of 2 and go on looking at the lung compliance, gas exchange, hemodynamics. And in between, at lower inflection point, lung will be like this. In between, usually a point where we get best compliance, best oxygenation, we stop. This is what we do in the normal PEEP titration. But in decremental PEEP titration, you don't stop here. You go on increasing the PEEP. You go to upper inflection point. Then you go up to like 30 centimeters of water for 30 seconds. That is full recruitment. And then when you're coming down, there is an upper inflection point at deflation limb. You have a very aerated lung now. So now, if you see, both are at same PEEP of 10. But because of recruitment maneuver, you have a much better aerated lung as compared to what it was by a simple PEEP titration. So that's how they demonstrated. And they found that this decremental PEEP titration maintains alveoli for a longer period of time. And this also has been shown by many other studies. These 4 studies have quoted here that level of post-recruitment PEEP is very important. And if you don't maintain that, repeated collapse and opening of the alveoli will lead to ventilator-induced lung injury. One more study by American Journal of Respiratory Critical Care, where end inspiratory non-aerated lung tissue was estimated for CT scan and gas volume, and they found that patients with high percentage of potential recruitability lung, the increase in PEEP markedly reduced the percentage of poorly aerated lungs. So it depends upon the lung recruitability. If the lung was not recruitable, as I already showed, that part of recruitability, if lung does not have potential for recruitment, then the impact of PEEP will be less. This is what they concluded, especially in ARDS patients with high recruitability, PEEP was beneficial. So how to understand that? In a CT scan, suppose you have a lung like this at a PEEP of 5 with so much atelectasis, and you applied a recruitment maneuver of 45 centimeters of water, there is hardly any change in the atelectatic lung. And this is a sign that this lung has a low potential for recruitability. When if there is a high potential for recruitability, at PEEP of 5, when there is so much atelectasis, you will see at 45 centimeters of water, much of the atelectated lung has become aerated. So this is a sign that this has got a high potential for recruitment. So impact of PEEP basically depends upon underlying lung condition. You cannot do recruitment maneuver for every patient, may not be safe. A very famous study, frequently cited in many recruitment articles, there's a Farlap study, which is a randomized control trial where one arm received the permissive hypercapnia, alveolar recruitment and low airway pressure strategy. Another had a normal ARDSNet guideline protocol, and they found that recruitment reduced the inflammation in the lung and also improved the compliance. So what we have seen is recruitment improves the lung compliance. If you look at the PV loop, as the recruitment improves the compliance, the PV loop will start moving away and away from the x-axis, and you will see the hysteresis also improving. Hysteresis is the distance between the inspiratory limb and the expiratory limb, and you are seeing that as the compliance is improving, it is moving away from the x-axis and improvement in the hysteresis. So that's how bedside you can monitor. In pressure control mode, since the PIP is fixed, then you need to look at tidal volume, and it will not have a typical hysteresis in pressure control mode because of variable flow. So you will see the tidal volume going on improving as the recruitment is successful. Going back to Borges et al. Study where they use this particular index of PO2 plus PCO2, we can see that they gave importance to PCO2. So recruitment is not just improvement in oxygenation and compliance, which we saw through two things. The third thing is the carbon dioxide. Gattinoni et al. Actually showed that in their study of prone patients, PO2 increasing above 20 centimeters of water were not predictive of patient's outcome, but reduction in PCO2 by more than 1 millimeters of mercury was. Similarly, this was another study by Protti et al. Where they also demonstrated that change in PCO2 but not in oxygen were associated with lung recruitability. That is why we need to also look at PCO2 and not just lung compliance and oxygenation. And we need to also understand that PCO2 changes. PCO2 can change because of metabolic conditions like metabolic acidosis and other things. So that also we need to understand. Both oxygenation as well as carbon dioxide clearance will also depend upon VQ ratio. So if you have a situation where blood supply is very good, but the alveoli are atelectatic, here the scenario will be different. Here you have a VQ ratio of 1, where there is a good air entry in the alveoli and good perfusion, and another situation where you have good air supply as well as, but there is a poor blood supply. So this is a shunt situation basically. If you perform a recruitment maneuver in areas where you have atelectasis but better perfusion, you will have a good response. This is a good response to recruitment. But in a situation when there is a shunting, as Anil sir was talking about, a situation where the blood pressure is only 20-22 and child is still hypoxic. So what's happening is the perfusion is the issue, and then you have to see whether nitric oxide helps or proning helps. Every time nitric oxide may not help because it may not be a vasospasm, it may be microthrombi in the blood vessels because of inflammation, but you can always give a trial of nitric oxide for 1 or 2 hours and see. This was a very important landmark study by Ranieri et al. Where they showed that in volume control mode at a constant flow, the dynamic PV loop corresponds or correlates with the static PV loop. And based upon that, extrapolating from that data, this concept of stress index came, where they are assuming that the slope of pressure time scalar, if the flow is constant, like in volume control mode, will give you an information about the underlying compliance. So if your stress index is 1, that is a straight line, that means the respiratory compliance remains constant throughout the tidal inflation. If it is less than 1, stress index less than 1, then there is a concavity downwards. That means there is a potential for recruitment, and you can increase the PEEP to better recruitment. And a stress index more than 1, when there is concavity upwards, that means the recruitment response may not be good. Actually, you need to reduce the PEEP little bit if possible. So this is how at the bedside, keeping on the volume control mode, you can do that, but it is still not validated in children, but you can try in older children and see. Coming to the last part of my talk, that is the recruitment to inflation ratio. Little complicated, but I'll try to simplify it as much as possible. The concept is simple. At a PEEP of 5, this is a static PV loop, and if you apply a PEEP on the top of that of 15 PEEP, suppose, then ideally what should happen, this PV loop should continue as an extension of this PV loop, but that is not happening. It is going little higher. So there is a gap between these two. This is the recruited volume. So what the concept is, you calculate the compliance of this recruited volume and then take the ratio of this compliance and the compliance at FRC or at 5 centimeters of water, and then that ratio will tell you about how much volume is getting distributed in the recruited lung. This is the concept. But measurement of static PV loop at a bedside in a patients with ARDS is not technically easy. That is why Lushan et al. They introduced another technique. What they did is, instead of increasing the PEEP from 5 to 15, they dropped the PEEP from 15 to 5. Okay, and then there are some equations by which they have calculated the C recruitment. They have calculated delta V recruitment. So when you are dropping the P from 15 to 5 suddenly, in first two breaths, you will see a volume displayed on the ventilator. So that volume they will take, and they will take difference of that volume with the calculated or expected ELV, and then that is your delta ELV, and delta P recruit is basically the difference between this and this. So that's how they will calculate this, and then they take ratio of this and simple compliance BT by delta driving pressure at 3/5. This is the compliance. They take this ratio. So if this ratio is less than 0.5, it means low potential for recruitment. And if the ratio is more than 1, it's a good potential for recruitment. So this is a simple bedside method of assessing. All in all, generally it is shown that CT scan and lung ultrasound show less percentage of recruited lung as compared to gas volume method. So if you look at some our scenarios, one scenario is totally atelectating lung, no air in the alveoli, because it is consolidated, and you apply recruitment maneuver, you will not see any air entering into this. So the consolidated alveoli with no entry after applying recruitment maneuver, there can still be improvement in oxygen. That is why I am saying don't look only on oxygenation. Why oxygenation will improve? Although there is no entry, but it is based on Henry's law. Henry's law means suppose there is a mixture of three gases, and you increase the mean airway pressure of the total mixture, then individual mean airway pressures of individual gases also increases spuriously. So when you increase the PEEP, saturation will improve. That doesn't mean that lung is recruiting. And second mechanism is there is already shunting going on in the lungs. And when you are increasing the intrathoracic pressure, you are increasing the right ventricular afterload, reducing the amount of blood entering into the lungs. So if less blood is flowing through the shunted parts, then naturally you will have better oxygenation spuriously. Compliance won't improve naturally because there is no change in the volume. PCO2 removal also will not improve. Another scenario is tidal recruitment. Tidal recruitment is when alveoli totally collapsed at the end of expiration and they are opening only at the end of inspiration. Naturally, compliance will show improvement because volume has changed. Oxygenation also may improve because of same Henry's law and because of less blood flowing through the shunt. But PCO2 removal will not improve because expiration is usually longer, and most of the part of the breath cycle, there is no air supply during expiration. So that is one thing. And second thing is because of repeated collapse and opening of the alveoli, there is increased risk of ventilator-induced lung injury also. And tidal recruitment can be picked up easily by ultrasound, electrical impedance tomography, and CT scan, as we already know. And gas volume methods also can be useful. Alveolar hyperinflation is also one situation. We in the morning saw about viral pneumonias, mycoplasma pneumonias with bronchospasm. So there will be a lot of air trapping, and there will be already intrinsic PEEP in the alveoli. And when you are applying higher PEEP, there will be even more hyperinflation. Compliance will improve because there is a change in the volume. So compliance will improve. Oxygenation also will improve because of Henry's law and because of less blood passing through the shunts. But PCO2 will not improve because of hyperinflation, and there is also risk of hemodynamic disturbances because of hyperinflation, also risk of barotrauma. The most ideal, that is actual recruitment, is called alveolar recruitment. Hyperinflation, is difficult to detect on CT scan, or because, as I said, already air is there and then you are adding more air, but gas volume methods are more useful. The most ideal is the alveolar recruitment, when you don't have hyperinflated alveoli at the end of expiration and you are getting a adequate lung expansion. So naturally compliance will improve, oxygenation will improve, PCO2 removal will also improve because perfusion is good in these areas. CT scan, lung ultrasound, everything can assess this recruitment. Gas volume method is supposed to be superior compared to CT scan methods. So the response to the lung recruitment will depend upon the underlying potential for lung recruitment. This we understood. Gas volume methods provide higher percentage of response as compared to CT scan or ultrasound. Successful lung recruitment should not be assessed only by improvement in lung compliance or oxygenation. You should also look at compliance, oxygenation, as well as better carbon dioxide removal and making sure that patient is hemodynamically stable. Decremental PEEP titration should follow recruitment maneuver to sustain positive effects of a recruitment maneuver. So this is the audience poll. Pilot 2 supports the use of recruitment maneuver in children. Yeah, so most of the people are already aware. Pilot 2 does not strongly support recruitment maneuver. They have given a cautious this thing that avoid sustained inflation should be avoided. Staircase method can be used only in recruitably lung in carefully selected patients. So not for all patients. A successful alveolar recruitment means improvement in compliance, improvement in oxygenation, better clearance of PCO2, any one of the above, all of the above. %95 of the people are right. Some people are thinking that it's only PCO2. That's not correct. So this is a combination of compliance, oxygenation, and carbon dioxide removal. Thank you.
Thank you, Farhan.
Recruitability will be higher. Not always, but most of the times. Rough rule of thumb. If you have a direct aspiration pneumonia, chemical pneumonia, viral pneumonias, you can see on the X-rays a lot of hyperinflation going on auscultation, lot of bronchospasm. Most likely not recruitable. Most likely, not always again. So this is general. Then at the bedside, you can just keep the PEEP of 5 and increase to in 2 electrodes 2 times, 5 to 7, 7 to 9, and look at the response to the compliance driving pressure. If you are on a volume control mode, you will see driving pressure, blood pressure coming down if the lung is recruitable. And then you know that, okay, I'm on the right track. So if you have a child with septic shock, ARDS or dengue ARDS, and with increase in the PEEP, your compliance is improving and driving pressure is coming down, oxygenation is also improving, carbon dioxide clearance is also a little better, then you do a recruitment maneuver and come down. If the patient is hemodynamically stable, which we discuss how to do, staircase method. But the moment you increase the PEEP, there is no change in the compliance, driving pressure is actually increasing or plateau pressure is worsening, then that's not an ideal situation. Better to avoid recruitment maneuver and manage with simple methods, or the best is, as already suggested, prone positioning. That is also a recruitment maneuver, but you are not taking the risk of going to plateau pressures of 30, staying there for 30 seconds and all that. Just put a recruitment. It is also indirect recruitment maneuver. Plus, it will improve the VQ mismatch. You are going to have better aeration in the dependent parts of the lungs, and slow recruitment through pronation also can be done. Sir, you have anything? Sir is asking, what is the difference between recruitment maneuver and PEEP titration? Is PEEP titration a recruitment maneuver? Madam? No. Technically, you can say if you're increasing the PEEP alveoli are opening, that's fine. But PEEP titration is you are just finding out the best PEEP to keep the alveoli open during expiration. But recruitment by definition is in the inspiration. Yes, sir. Sir, mic, mic.
The recruitment maneuver is sudden change in transpiratory pressure, a brief and sustained change. That is actual definition of recruitment maneuver. PEEP titration is step by step. But then you are doing it, every 2 minutes you are increasing. Yeah, there is some overlap, but I am telling you the exact definition. It's sudden, sustained, brief increase in transpiratory pressure. That is recruitment.
Now, the staircase method is also done within 5-10 minutes. No, you are not doing very slowly. You are increasing the PEEP slowly, but you are going to stay at one PEEP for 2 minutes, another PEEP for 2 minutes. Hardly 4 or 5 steps, you will reach 30 centimeters of water. So how much? Roughly around within 10 minutes, the 4 procedure is done. So that is also like a sudden increase in the transplant.
Dr. Farhan, see, I agree, it may not be defined that way, but if you're increasing PEEP and you're keeping driving pressure same, right? You do say 5 minutes, 10 minutes, means somehow you're also increasing, means at the end of inspiration, you will reach some point, PEEP has been increased to like 15 and your driving pressure is same, so total pressure might be 22 or 30. Right? And that is required to open up the alveoli. So you're recruiting some way. It cannot be defined like an adult, but you're recruiting, isn't it? Because most of us, means I don't know about you, In our unit also, we do PEEP titration and gradually we come to that compliance, not sudden way.
Yes,
Right.
yes. So basically, recruitment maneuver, this term is used for at the end of inspiration, how many alveoli, that is what Gattinoni has defined it basically, that at a PEEP of 5, when it is atelectatic, and at a PEEP of 45 centimeters of water, how many lungs alveoli opened up. That's how they defined, that's why it's going on. But of course, when you are increasing any mean airway pressure and recruiting the alveoli which were not previously open, it is a kind of recruitment maneuver. But when you're talking scientifically, recruitment maneuver is change in the transpleural pressure to achieve aeration, and then you do a PEEP titration when you're coming down. Don't reduce the PEEP suddenly, go back to the earlier PEEP, go down slowly, and then titrate the PEEP or the decelerating link of the PV loop. That is a decremental PEEP titration.
In simple terms, recruitment is a phenomenon.
Yes, sir.
Either you achieved by maneuver, that is recruitment maneuver, or by PEEP titration.
Yes, sir.
Ultimately, it is the opening of the
Previously closed.
openable alveoli. It's a phenomenon.
Yes.
In your talk, you said recruitment happens at
End of inspiration.
end of, that is PIP, right? And as a method of opening lung, you are using PEEP. Now, is it not a irony? I mean, is it an understanding difference that you are titrating the PEEP to gain the PIP? At other end, you are seeing PIP and delta P is harmful. Now, just explain this irony.
Yes, sir. See, the thing is, the definition, by definition, PEEP is what? Positive end expiratory pressure. It's an expiratory pressure. It is applied during expiration. So in the PV loop, there is inspiration and there is expiration. That is why ideally PEEP should be titrated in the expiration. Because you are going to use that PEEP during expiration, so it should keep the alveoli open during expiration. Recruitment maneuver is, by definition, achieving opening the alveoli suddenly by increasing the transpleural pressure. Previously, it was a sustained inflation. Then people found that a lot of barotrauma, hemodynamic disturbances happen. So they devised this staircase method. And then they said, after doing that, some people used to come back to earlier PEEP. They used to keep 2 centimeters above that arbitrarily. Then the Borges et al. Showed that if you do a decremental PEEP titration, when you don't come down suddenly, come down slowly and titrate PEEP while coming down, that PEEP which you titrated maintains the alveoli open, which you achieved during inspiratory recruitment maneuver for a longer period compared to a PEEP titration which is done by simple. This is what is the thing. Basically, increasing the PEEP is increasing the mean airway pressure in the system and opening the alveoli. So recruitment, that is why is considered as an inspiratory phenomenon, and PEEP titration is to maintain that advantage and not allowing the alveoli again to collapse.
I have a question. Thank you very much.